So I just thought I'd put in the clinical perspective in terms of why we do certain things with adjuvant chemotherapy, and really how far we've come with adjuvant treatments in breast cancer, as well as really some of the cardiac toxic drugs that we use and the common schedules that we use. And also give you a bit of an idea of who's actually offered chemotherapy, which I think is probably an increasing number of patients as opposed to what it was perhaps 20 years ago. And also go through really what benefits these agents offer these patients and why we're so keen for these patients to be able to continue treatment if they can. And also a little bit of information about dose intensity and timing of chemotherapy and why dose is so important to us, why timing matters, and why getting in early and getting all their cardiac issues sorted out early is important for us. Okay. And also go through some interesting things that are going to be happening in breast cancer. So I think everyone's probably aware of really the changing face of breast cancer. While we've got an increased incidence of breast cancer, which probably is coming from early detection, we've actually got a declining mortality rate. And that's as a result of both increased early detection and also adjuvant treatments. And what we can see in this graph is really an increase in the 5-year survival. And you can probably actually even mark the points where adjuvant treatments changed. So in the early 90s would have been really the introduction of CMF, and you can see there's a bit of a blip in terms of increasing 5-year survival. In the mid-90s we would have got the anthracyclines, and again an increase in survival. 2000 really saw the mark of taxanes, and then Herceptin came in around sort of 2009. So these are the typical adjuvant regimens that we would use that are potentially cardiotoxic. So FEC 6 cycles is probably something that's not used very commonly anymore, but is still around. And this involves basically 6 cycles of an anthracycline. FEC docetaxel probably is a lot more common, and that's used with or without Herceptin, depending on whether the patient's HER2 positive. AC paclitaxel, again, very common regimen with or without Herceptin. And then if we are concerned about patients' cardiac function, for the HER2 positive population, we do have an anthracycline sparing combination with docetaxel and carboplatin. And really, I think the number of people who are offered chemotherapy is actually expanding. So traditionally, it's been node-positive disease, but there are patients who are node-negative who would get a benefit, and they would be patients who have more aggressive disease or who you're concerned that they would have a recurrence. Tumours that are greater than 1 centimetre all have some kind of benefit from chemotherapy. Now, sometimes that benefit might be 3 or 4%, and that patient probably wouldn't go ahead with chemo, and that wouldn't be something that we would offer. But there is actually a benefit for patients over 1 centimetre in size. High-grade tumours get a benefit. Tumours that aren't very sensitive to oestrogen, so we have no other way of really tackling their treatment, would be offered chemotherapy, and they're classically what we would classify as luminal B cancers. Again, triple-negative tumours have no other way that we can treat their tumour, and so they would also be offered chemotherapy. HER2-positive cancers traditionally are very aggressive, and we know that Herceptin works better with chemotherapy. Premenopausal women get potentially multiple advantages from chemotherapy. They tend to have more aggressive tumours, and also probably there's some benefit from making these women postmenopausal if they're ER positive. And I think the conventional kind of perception of age cutoffs has really been blurred with our population, you know, someone in their 70s actually being very healthy and fit and active. So in terms of benefits based on age, this is a patient population less than 50. It doesn't really matter if you're node negative or you're node positive. these patients actually get a very substantial benefit from chemotherapy. If you're older than 50 and up to 69, you still have a benefit from chemotherapy. It's not as great as that younger population, but it's still there, and they still warrant a discussion about the benefits. In terms of benefits from the agent, so anthracycline treatments are very potent chemotherapy for us. And what you can see, I've cut off the bottom of both of these graphs, unfortunately, but basically towards the left, the agent does better, towards the right, the agent does worse. And the anthracycline is this second one here, and you can see that there's a substantial benefit from patients receiving some kind of anthracycline-based therapy. And if you compare, the next graph actually goes through a comparison of CMF compared to anthracyclines. And what we can see from that is basically if patients have some kind of anthracycline versus a non-anthracycline regimen, they get a benefit from that as well. In terms of Herceptin, which would be, I guess, the other most common cardiotoxic drug that we would use, there's lots of follow-up data now, up to 10 years, that shows that Herceptin has very significant survival advantages for patients who are HER2 positive with a hazard ratio that's very significant. And so what you can see is patients who are HER2 negative without trastuzumab, the light blue line, if you actually give them trastuzumab, they have a very substantial benefit from their Herceptin. And in terms of cardiotoxicity in the trials that have been reported, I've stolen this slide from Thomas Suter, who I guess is probably one of the cardiologists who's been involved in most of the adjuvant trials for Herceptin. You can see that the rates of heart failure that are 3 and 4 are actually all below 5%. And while the cardiac dysfunction is a little bit higher, kind of closer to that 15 to 20% mark, patients who are ultimately having very severe cardiac dysfunction is very low. And in terms of anthracycline-sparing regimens, this is the docetaxel arm, which shows a very low rate of stage 3-4 heart failure. And Peter had talked about this, but this would be really the very common algorithm that's used in all of those adjuvant trials, which basically is looking at overall ejection fraction, so being less than above or above 50%. If patients have an ejection fraction that's above 50% and they drop less than 20 percentage points, then they would be continuing treatment. Above 50%, greater than 20% point drop, they would continue treatment, but you would repeat their scan. And then this is for when they actually drop below 50% and they have an ejection drop of greater than 10 percentage points. And then you might consider stopping treatment and redoing the echo, and if it's okay, resuming treatment, otherwise stopping treatment. So this would be the conventional algorithm that's really used in all of the adjuvant trials. So just moving on about why we're keen to really continue treatment. Dose is really important. So we don't actually want to do dose reductions for our patients unless we really have to. And this is a very old trial, and not looking at anthracyclines, but looking at CMF chemo. And what this shows is that if you have greater than 85% of your scheduled dose, which is all calculated on height and weight, you actually have a good chance of relapse-free survival. But as soon as you start dropping that to below 85%, your survival drops very significantly. Essentially, we actually don't want to fiddle around with the dose unless we have to. The timing of chemotherapy is also really important. So we don't want to have dose delays. And this is a retrospective analysis looking at anthracycline-based treatment. And what they did was they looked at people who had less than dose delays of less than 2 cycles or greater than 2 cycles, delayed days in terms of greater than 15 days or less than 15 days, and dose reductions with that 85% or less than 85%. And basically, if your treatment is delayed by 2 cycles or 15 days, or you have less than 85% of the dose, it affects your disease-free survival and it affects your overall survival. There's also a little bit of data that suggests that we actually should be getting in early with some subtypes of breast cancer. This was an analysis of 3 trials, again looking at CMF chemotherapy, and what they actually showed was that if you had your treatment less than 21 days, you actually had a benefit in terms of your disease-free survival if you had estrogen receptor negative disease, which would be a bad adverse prognostic factor. If you had disease that was just ER low, you still had an effect in terms of outcome, but not as significant. And if you had ER positive disease, it probably wasn't that much of a concern if you didn't get your chemotherapy in within 3 weeks. And what this is really showing is that there is an effect on the overall population in terms of overall survival, but if you divide this up, what you see is the effect is really in patients who have advanced disease, so stage 3, and patients who have aggressive disease, which would classically be a triple negative breast cancer. And the same was seen in patients that were HER2 positive. So for certain groups of patients, you actually want to get your chemotherapy in quite early, which means that if they do have a cardiac history, that all needs to be sorted out very quickly. And these are some guidelines from ESMO, which basically state that you should start your treatment within 2 to 6 weeks from surgery. Otherwise, there could be a significant decrease in efficacy if it's administered more than 12 weeks from surgery. Now, this is really some interesting things that are going to be coming in breast cancer, and based on some new PBS listings for some new anti-HER2 drugs. So doublet therapy is probably going to start to take more of a feature. Pertuzumab is a new agent. It's a monoclonal antibody. It works by basically inhibiting the dimerization between the HER family of receptors, particularly HER2 and HER3, which is a particularly potent combination. And once these dimerize, they basically set off a whole series of reactions within the breast cancer cell that keep that cell proliferating. And in the metastatic setting, the Cleopatra trial has really demonstrated a very significant survival advantage for patients having doublet anti-HER2 therapy. So their median survival has gone from 40 months to about 56 months, which is very significant, about 16 months increase. Interestingly, you would think that combining 2 anti-HER2 agents, you would potentially increase the cardiotoxicity. And that's actually not what was seen in the Cleopatra trial. So in this column, you can see standard of care with trastuzumab and docetaxel. In this, you see the doublet therapy with docetaxel chemotherapy. And what you can see is that patients who had a decline to less than 50% and greater than 10 percentage points was actually slightly less in the doublet arm in comparison to the standard Herceptin arm. Patients who recovered treatment were, I guess, similar in both arms, and patients who recovered to greater than 50% after stopping treatment was higher in the doublet arm, and the total number of patients who recovered was greater in the doublet arm as well. So interesting thoughts. And something that was also a very interesting study, which has probably challenged a lot of our notions about anthracyclines and Herceptin, was this very small study called Trifina, where basically they gave patients their neoadjuvant chemotherapy, and then they had surgery, and then they continued with their Herceptin. And they randomised 225 patients to 3 different groups. In the first group, patients received docetaxel, and they had their doublet therapy at the same time as their anthracycline, which is quite unusual because we always separate those for the purpose of trying to really minimise the combined cardiac toxicity of the anthracycline and the HER2. Then we have the standard docetaxel with the trastuzumab after the anthracycline, and then we have this anthracycline sparing regimen with the concurrent doublet therapy. And what they found in this study was that actually the rates of cardiac toxicity weren't significantly higher when you combined the anthracycline and the anti-HER2 therapy at the same time. So symptomatic left ventricular dysfunction didn't really happen in the study at all. Any kind of dysfunction, it was probably a little bit higher in the combined arm as opposed to the separated arm and the anthracycline sparing arm, and then an ejection fraction decline of greater than or equal to 10 percentage points was actually quite comparable, if not a little bit less, than the separated arm. And if you look at the mean change in ejection fraction, really all of the 3 arms almost overlie each other. So what I wanted to get across today was really we've made lots of gains with breast cancer survival, and that's been in part with adjuvant treatments, some of which are cardiotoxic. We, as oncologists, really like to deliver treatments on time and at the scheduled dose because that's actually quite important for survival. And understanding the type of cardiac toxicity that occurs with each agent is also important. And it's really important to have a really good collaboration with the cardiologists that are helping us monitor our patients.